identify endoleaks, describe the management of the left subclavian artery, and then to go over some sizing and planning for stent graft cases, in particular looking specifically at a type B dissection case and then a case involving a descending thoracic aortic aneurysm. Briefly, the blood supply to the spinal cord is as follows. These are all very important points and slides because I actually think several of them were actually on my exam quite a while back. But primarily, branches from the vertebral artery supply the anterior longitudinal spinal artery, as well as the paired posterior longitudinal spinal arteries. And there are segmental vessels, spinal arteries, and one of the key vessels that we're always interested in trying to identify, if possible, is a major vessel called the artery of Adamowicz. Looking specifically at risk factors for spinal cord ischemia, anything that will affect the blood supply and perfusion pressure will be recognized as influencing this devastating complication. Age, perioperative hypotension, this can also include significant blood loss, emergency surgeries, prior aortic surgeries, in particular those below the diaphragm, are well recognized as increasing the risk factors. That one in particular is because the collateral blood supply to the spinal cord can be sacrificed from previous, for example, infrarenal aortic aneurysm repairs. People that have preoperative neurologic findings before surgery, that is always concerning. And the length of aorta either covered or resected, excuse me, is a risk factor for spinal cord ischemia. Namely, the more pairs of intercostal arteries you are sacrificing, either by cutting out that section of the aorta or covering with stent grafts, will influence that spinal cord ischemic risk. And any major collaterals that have been sacrificed, either at a separate procedure beforehand or at the time of your specific intervention. Looking specifically at open surgical repair, aortic cross-clamp times of greater than 30 minutes are associated with spinal cord ischemia, as well as the lack of distal perfusion adjuncts. And a lot of how surgical procedures are conducted, in particular with open descending thoracic aortic aneurysms, we will try and tailor the surgical approach to include distal perfusion if possible. So knowing that there's a huge host of risk factors, what can we actually do to improve spinal cord protection? Number one, the use of CSF drains is very important and helpful. Judicious use of hypothermia along with, in association with the cardiopulmonary bypass machine can be protective. Left heart bypass or other distal perfusion adjuncts will also protect the spinal cord. I was trained using left heart bypass, but now I just use a full cardiopulmonary bypass. Although many centers very successfully do use left heart bypass, there are some technical considerations that you have to factor in if you are going to be doing that. Reimplantation of intercostals, avoidance of hypotension and hypovolemia. This requires a careful coordination with both perfusion as well as anesthesia. The use of intraoperative monitoring for spinal evoked sensory evoked potentials or motor evoked potentials can be helpful in terms of trying to identify what would be the minimum blood pressure that would be tolerated by the spinal cord. Knowing, for example, that if you have intact SEPs and MEPs at a MAP of 65, you'd be able to safely go back to the intensive care unit knowing you have an intact spinal cord, and then be able to very carefully instruct to the intensivist, the people receiving your patient, that you want your blood pressure maintained above that, that target value. And incredibly important, Q1H, Q hourly vital signs, neurovital signs in intensive care unit is incredibly important. It is the one thing that we can do for our patient that we will be asked to often not do. It's very common for the nursing staff as well as the intensivists to ask if we can decrease, an hourly assessment. They'll say, "Oh, you're waking up the patient too often. The patient can't sleep. Is this something that we can do for them?" But in the first 24, 48 hours, it is absolutely critical that we do identify evidence of spinal cord ischemia, because if your patient gets to the ICU with an intact spinal cord, if there is any development of spinal cord ischemia, in most cases, it should be able to be rescued. If you don't know what's going on for 6 hours, you will potentially have irreversible injury that may have been avoided if we identified it early. Briefly, a slide on endoleaks. An endoleak is just effectively a failure to exclude the aneurysm sac. Proximally and distally, we are aiming to seal and exclude the aneurysm. By excluding the aneurysm from blood flow that is pressurized, the goal is to decrease the risk of complications of ongoing aneurysmal growth and the potential for rupture. The first type of endoleak are type 1 endoleaks, and these are inadequate seals at the graft ends. The most common ones that we deal with is in cardiac surgery are type 1A and type 1B, proximal being 1A and 1B being distal. If you identify a type 1 endoleak, whether it's proximal or distal, it's generally accepted that these will not improve on their own, and an intervention will be required to address this, whether it's a secondary endovascular intervention or an open surgical procedure. Type 2 endoleaks are endoleaks as a result of filling of the aneurysm sac from a side branch. And this is retrograde flow through collaterals that feed into the aneurysm sac. And in this image of the infrarenal abdominal aortic aneurysm, this would be potentially just a lumbar vessel or an inferior mesenteric artery vessel feeding this aneurysm sac. Type 3 endoleaks are leaks through the graft, whether most commonly between components of the graft, and with either angiography or MRI, and sometimes can be identified with the delayed venous phases of CTAs. We can identify where those leaks are occurring. Type 4 endoleaks, graft porosity, almost is much less common these days with the current stent grafts that we have available. But this was something that was much more common with some of the older stent grafts. And type 5 is where we just call that endotension, where we actually cannot identify where the endoleak is coming from. The left subclavian artery, do we revascularize it or not? For elective TEVAR, where we are covering the left subclavian artery, the current recommendation is that if you have time to consider preoperative revascularization. This is incredibly important if we also identify preoperatively via a dominant vertebral, a left vertebral artery. In emergencies where people are having stent graft interventions, either for rupture or a dissection on an emergent basis, if there is instability, I think one could forego revascularizing the left subclavian artery, but it should be dependent on the individual case. Other factors that should be considered: if there is the presence of a patent left intramemory artery going to the LED, for example, that is definitely a case where we would want to revascularize the left subclavian. If there's a dominant left vertebral, if there's an occluded atretic or absent right vertebral, people that have AV shunts in the left arm, we should obviously consider revascularization. And people that have had previous infrarenal abdominal aortic aneurysm repairs. This is the opposite example of where I said people that have had prior infrarenal repairs are at higher risk of spinal cord ischemia. These would be people that we want to make sure that we are trying to decrease their risks because they've had previous sacrifice of lumbar vessels, and any cases where we're covering large areas or lengths of the descending thoracic aorta. and people that have hypogastric artery occlusion, which is not uncommon in people with significant peripheral arterial disease. This is another group where spinal cord ischemia can be minimized by maintaining collateral blood flow via the left subclavian artery. So one of the main areas that we see stent graft use is in the type B aortic dissections. And the interventions are based on usually complicated type B dissections, those that have significant aortic expansion, evidence of imminent or contained aortic rupture, people with hemodynamic instability, those that we can't control them medically, and whether it's resistance to hypertension control or ongoing chest pain despite best medical management, and people that have malperfusion syndrome. So the current guidelines for type B recommendations are as follows. I'm not going to go through them all, but we can refer to this after the fact. So the first case is going to be of a type B aortic dissection. And I'm just going to load that up. Just give me one moment here. My apologies. Any questions so far while I load this up? I just want to anonymize it before it pops up on the screen for you.
Dr. Moon.
Yes.
Can you hear me?
Yes.
What are some rescue strategies that you use if the patient do get into spinal cord ischemia post-op?
That's a good question. The only option that we really have is to drive the blood pressure up. And if they don't have a CSF drain, place a CSF drain, take fluid off, and try and increase their spinal cord perfusion pressure. So by decreasing the pressure in the spinal of the CSF pressure and increasing your mean arterial pressure. So,
thanks.
Okay, so what I'm going to do is I'm just going to change screens here. Share screen. Okay, can everyone see the workstation screen that just popped up?
Yes.
Mm-hmm. Okay, perfect. So for those of you that are not familiar with this software, what we're looking at is the Aquarius Intuition software of the Terra Recon workstation. And this is similar to the software that comes standard on any CT scanner. And if you go down to the radiology department, you'll see in many cases your radiologists using this type of information. Just briefly here, I'm just going to scroll through the images that we're going to be looking at here. This is a CT scan of a 78-year-old gentleman. And just scrolling down through the chest, we can see that there are some abnormalities of this CT scan. One of the first things that I do when I look at a CT scan is you like looking at a chest X, so you want to have some sort of routine. And my particular routine is to always start at the aortic valve, and then I work my way around the aorta, going down to the bifurcation. And before I make any firm diagnosis in my mind, I like to actually look at the whole aorta. So starting at the aortic valve here, heading up toward the ascending aorta, we're heading up to the proximal aortic arch, and then we start seeing some head vessels arise. We can see the nominate artery, left common carotid artery, and then the left subclavian artery. Coming down into the descending thoracic aorta, there's some abnormalities present. Through the descending thoracic aorta, approaching the diaphragmatic hiatus, celiac, SMA, left and right renals, infrarenal aorta, aortic bifurcation, and then the two lower extremity vessels. In the aortic arch, the common tendency for all of us is to right away focus on the pathology, but to try and plan surgical procedures, try and plan interventions, we need to know what the anatomy is. And if we think about the slide talking about the left subclavian artery revascularization, one of the things I want to see is, can we identify if there are vertebral arteries present? That is important because if we are going to cover the left subclavian artery and there is particular dominance for the left vertebral artery, absence of the right vertebral artery, we can have devastating complications to the patient, not just for spinal cord ischemia, but also for posterior circulation strokes. And in this particular CT scan, we can see that the left subclavian artery gives rise to a huge dominant left vertebral artery. And it's almost the size of his left vertebral artery is the size of his right common carotid artery. And I don't get the sense that there is actually any right vertebral artery, at least in the images shown here. So this would be a patient that we would be very concerned about covering up the left subclavian artery without preoperative revascularization, even in the urgent setting, unless the patient had actually ruptured and was imminently dying, but I would have serious concerns about the potential for posterior stroke. So these are axial images, and then down in the bottom left-hand corner, we have coronal images, and then the sagittal images are in the bottom right-hand corner. What we are going to do is try and view the images in an axial form and just get the sense of, what is the disadvantage of just using axial images when we're trying to size for a stent graft. And one of the limiting factors is measuring length is almost impossible. It can be done, but you definitely have to use a combination of the sagittal and coronal images. But if we say, okay, what's how much length is there between the dissection that is in this area here and the origin of the left subclavian artery? It's not particularly easy to make that. You may try and draw some. You may try and do something like that and say, oh, we have 28 millimeters, I think, to that tear. Perhaps not, maybe a little bit less. If you're actually trying to get a diameter of the aorta at the level of subclavian artery, are you going to just draw a line across the screen like this? And I think that's what a lot of people will do. You may try and get a little bit more sophisticated and actually look in, using a multiplanar reconstruction and trying to get a sense of, if I say this is the origin, this is where the left subclavian artery is and the tear is a little bit posterior, how far is that away? But multiplanar reconstruction allows us to actually get very accurate measurements if you are aligned properly in orthogonal perpendicular views or perpendicular points to the long axis of the blood flow. But the strength of the workstation is actually being able to do what we call a centerline reconstruction. And you read all the operative reports, all the radiology reports, they will talk about centerline reconstruction. So what we're going to do is, every software is slightly different, but TerraRecon allows us to do a centerline by selecting this button here. And what has happened is the aorta, which is going to be straightened out, including all the way from the iliac vessels, is represented in this picture here. And on the right-hand side of the screen is the whole vascular system. The heart is at the very top, it's upside down. The aortic valve is here. We see the sinotubular junction, the ascending aorta, and over here we see some head vessels. I'm just going to zoom in for you guys. So if we look at the blue line that is scrolling, this blue line in the left-hand lower panel is showing us the cross section of the aorta. And for the most part, it looks quite round. And the reason it's round is the aorta, which was previously tortuous, has now been straightened out in a single straight line. And this is how you will be wanting to do your measurements and your distance measurements. I'm just going to delete these pre-made measurements, and we can do our own here. But we can see where the blue line is in the center of the inaugural artery, moving it distally. It is now in the center of the left common carotid artery or ostia, and then down in the center of the left subclavian artery. As we scroll down distally, we can see that the aorta, which is intact in the left lower panel, as we go distally, we see the evidence of the dissection. And the true lumen is on the left, and this is the false lumen on the right. As we scroll further distally, we will see that the tear is occurring and in the 7 o'clock position in this representation. So I'm going proximal, and this is where the tear has occurred. And the tear, I'm just going to mark with a red line, is only between these two marks here. Why is this important? Because we need to determine how much aorta, how much healthy aorta there is before the subclavian artery, and if we need to cover the left subclavian artery, how much length we have to the left common carotid artery. So we have 37 millimeters to the tear from the left common carotid artery. And if we are measuring to the left subclavian artery, we only have 26 millimeters. And if you actually want to look at how much normal aorta there is, you only have, we have 3 measurements on the screen here. We only have about 3 millimeters of, that number changed there. We only have about 3 millimeters of aorta that is between the most distal aspect of the left subclavian artery and the onset of where the aorta is actually dissected. So that's important because we need to know that if we are going to be wanting to treat this in an endovascular manner, a strong consideration has to be made to cover the left subclavian artery to be able to adequately seal, because a seal is only considered including healthy, undiseased aorta. So when we talk about the measurements, if we move our cursor, the blue line, to just distal to the left common carotid artery, we'll see a circle here in the left-hand panel. And if we just measure, we can measure in 2 different planes here. Aorta is anywhere between 34 and 36 millimeters. So when we're sizing for dissections, the goal for oversizing is a range between 0 and 10%. So stent grafts come in 2 millimeter increments in even numbers. So there we have stent grafts that are 32, 34, 36, 38, 40, for example. And you have to pick the larger of the 2 values. So 10% greater than 36 is 40 millimeters. So the largest stent that we would want to consider would be using a 40 millimeter stent. And you could argue using a 38 millimeter. A 38 millimeter stent would be around a 2 millimeter oversize. And a 40 millimeter stent would be a 4 millimeter oversize, which would be just above and below 10%. And either of those would be reasonable. What would guide what we would ultimately choose would be potentially what the size of the aorta will be distally. And, depending on what type of stents you have on the shelf or have access to, there are catalogs which tell you how long each individual stent will be based on its diameter. So if I say that the stent's going to be 117 millimeters in length, and I want to see how far my aorta is going to be, or what size my aorta is going to be, 117 millimeters from the left subclavian or left carotid artery, aorta measures 45 millimeters in this region here. So your 40, if we pick a 40 millimeter stent, we will not be fully excluding or fully filling the potential size of the aorta, which includes both the true and false lumen in this area. What you don't want is to be picking too large a stent in a dissected aorta, because there's concern for causing either a new entry tear at any point along the aorta if it is much smaller, for example. So if this aorta were only sitting at 30 millimeters in size, and you have an aorta, a stent graft that is 40 millimeters in size, at the bottom end, we have now potentially oversized by 33%. And the concern would be that this injured aorta would be at risk of having either a new entry tear develop distally, or potentially even causing injury to the integrity of the aorta and resulting in significant catastrophe distally. Now, I know that we're going to leave some questions or ask some questions at the very end. Does anyone have any questions about what we've talked about right now? This would be a good time to ask for this case.
I'm just curious, how far along would you plan to cover the aorta here? Like, other than whatever limitation you have from the stents that are on the shelf?
That's a very good question. I think that the current recommendation, both with both cardiac and vascular surgeons, is to use to cover the entry tear number one, and to try and use the shortest stent possible that is covered. And then there are people that philosophically believe that bare metal stents should be placed throughout the remainder of the diseased aortic segments to try and re-expand the true lumen. I fall into that category, so I do like to use bare metal stents that don't have any cloth material that would cover any side branches. So I would place the shortest stent possible that would allow me to seal proximally and cover the entry tear. If the entry tear is more distal, you may need to use a longer stent, but I still want to seal as close as I can to the subclavian artery. And then I would place bare metal stents all the way down to the level of the visceral vessels.
Great, thank you.
Any other questions?
Sorry, just to clarify, so you will be using a cover stent proximally.
Correct.
And potentially using a dissection stent distally to extend the coverage.
Yes, and the main reason is to try and support the true lumen stented open, and decrease the potential for any malperfusion, number one, and enhance aortic remodeling. If you can imagine, even though you've covered the entry tear distally with a covered stent, if you don't support the true lumen, blood can still exit out the ostia of the visceral vessels into the false lumen and pressurize it and result in malperfusion at that level. So by supporting the true lumen open, you can avoid having that collapse completely and decrease that risk of malperfusion. And by keeping that aorta open with the bare metal stents in the true lumen, there's increasing evidence that we can improve aortic remodeling and help at least try and heal the descending thoracic aortic segment. Okay, so I think the key point for the descending thoracic aortic, the aortic dissections, is to try and limit your oversizing between 0 and 10%. Your stent graft has to be at least the size of your vessel. And if you are in a half size, if you're in an odd number, if you measure 33 millimeters, you don't want to pick a 30 millimeter stent graft. It's not going to work, in which case you have to go up. If you think that your aorta, where your stent graft is going to be sitting is relatively straight, just in the descending thoracic aorta, if your aorta measures 32, I think you could get away with the 32 if you didn't feel comfortable putting a 34 millimeter stent graft. But 10% would definitely allow you to go up one size, and that would be something that you'd be very comfortable doing. So 32 would take you up to just over 35, and then that becomes a sort of a judgment call. Do you use a 34 or 36? I think a very important point is, as you get exposed to more of these cases, it is important to specifically ask why the surgeon or the vascular surgeon or the interventionalist did pick that stent. And you can ask, why did you, I noticed that today was 5% oversizing, and the next time you went, you accepted 11%. Was there any particular reason that you felt comfortable doing that? So we're just going to jump to the second case here, and the request was we just go over a CT scan looking at descending thoracic aortic aneurysm. So one quick point that I didn't talk about at the first CT scan is when you load up the CT scans, they often look like this. What I mean by that is you can tell it's a contrast enhanced study. There's a huge amount of contrast. You can see that the aorta is nice, bright white. But the problem with this is the contrast is the exact same density as the bone. And it becomes very difficult to be able to appreciate if there's any calcium. So the first thing I always do routinely is I window and level it so I can potentially identify if there's any calcium. So just for example, right here, there's a bit of calcium anteriorly in the descending thoracic aorta. So you want to window and level so you can appreciate it. So if it starts off like this, it's not that helpful. You just adjust your window and level so you can see that. And that's that's the first step that I do. Similarly, we have this 84-year-old man, the CT scan. I start at the aortic valve, STJ, ascending aorta, proximal aortic arch, the head vessels coming off the top, and then coming around the bottom, the proximal descending thoracic aorta, something's going on there. Then we have the descending thoracic aorta going through the hiatus, celiac, SMA, both renals, infrarenal aorta, and iliacs and femorals. Going back up to the top again, trying to see if we have any discrepancy between the vertebral arteries. The vertebral left and right vertebrals look quite equal. Doesn't mean that you have an intact circle of Willis, but it's a little bit less concerning than the previous CT scan, which showed the dominant left vertebral artery. One observation is this patient has a pathology in the proximal descending thoracic aorta. People that have pathology in the proximal descending thoracic aorta, you will almost always notice that their head vessels, the arch vessels, will be pushed proximally. That's because the descending thoracic aorta displaces everything proximally. The alternative is also true. If you have a very large ascending aortic aneurysm, the head vessels get pushed distally. And we can see that the left common carotid artery, makes a 90-degree corner here and actually lies completely lateral just before it heads straight up toward the head. But that's because the origin of it has been pushed anteriorly. So when we are looking at the CT scan, again, we have axial images. It can be quite challenging to actually make proper measurements. And if you're measuring off the axial screen, your measurements and lengths will not be as accurate. If you are able to use the multiplanar reconstruction views, you can actually get quite accurate measurements, but again, what's going to be a lot easier is going to be using the center line. So the image on the top left and the bottom right are perpendicular in two separate perpendicular in two different axes. What results is you actually get a perfect circle for the mid-aortic arch. And the aorta, if you're transecting the aorta perpendicular to the long axis at any point, you should always get a circle. And that tells you that you have a proper orientation. And you, in theory, could make a measurement of the diameter based on the bottom left-hand corner for diameter, but we won't be able to measure length. So we will try and do a center line here. Okay. So you can see that we're going to extract the center line. The top image here on the right-hand side is going to be where the center line was drawn. And you want to see that it actually does go through the aorta. The images on the left upper hand panel are representative of what that aorta will look like, although it is not physically straightened out yet. And to do all of our measurements, we will always use a configuration that looks like this. Again, the orientation, the heart is at the top with the apex of the ventricle at the very, very top. The blue line is going to be sitting right now at the aortic annulus, STJ, ascending aorta. We don't see any head vessels because I'm spinning this on its axis. And we're going to hopefully see some head vessels come through here. So as I move the blue line, this is an ascending aorta. The inaugural artery is coming off here. We can see that in the bottom left-hand corner. This is the inaugural artery coming off. The next vessel to come off is going to be the left common carotid artery. And then there is the origin of the left subclavian artery. As we come down distally, just as we are having the left subclavian artery come off, the left subclavian artery actually comes off, and the aorta in the left-hand panel actually looks quite round. But as soon as we go immediately distal to it, we start seeing that there is some thrombus that is present in the aneurysm in the distal aortic arch proximal descending thoracic aorta. And as you go further distal, we can see that this aneurysm is increasing in size. And then right here, my center line is a little bit odd, but this is probably the largest area of the descending thoracic aortic aneurysm here. This is a patient that was actually referred for an intervention with a lot of back pain, but it ended up being that he had a significant cervical spinal stenosis, and the back pain that he was having was likely not related to his thoracic aneurysm. So his aorta measures 58 millimeters in maximal dimensions. And then the question is, how are we actually going to pick a stent graft size for him? Again, if this is the origin of, so, you know, he has no, there's no real length between the left subclavian artery and the onset of the pathology. So as soon as I go a millimeter beyond the left subclavian artery, we start seeing abnormal aorta. And you need to have normal aorta to seal. So going proximally toward the left common carotid artery, we can see the left common carotid artery comes in here, and there is 24 millimeters, which would be the minimum in terms of sealing. Ideally, I like to have at least 20 millimeters to seal proximally, and anything less I would not feel comfortable accepting. So between his left common carotid artery and his aneurysm, we have 24 millimeters. So because we know that this is a centerline measurement, we can measure the aorta in two directions to try and get a sense. So his aorta measures 35 by 38 millimeters in size. Unlike aortic dissections, you have to greatly oversize your aneurysms to seal. And I would recommend that we oversize by at least 20%. One of the reasons for that is that if you don't oversize large enough and the aorta continues to grow in your sealing zone, you will no longer achieve a proper seal, and you're at risk of developing type 1A, in this case, approximately type 1A endoleak. So if you say 37.6 times 22, you would have to pick, 20% oversize here would be 44 millimeter stent graft, which is at the upper end of what is available. But I think that you would have to at least pick a 44 millimeter stent graft. If you think about this, the mid-aortic arch is not supposed to be 38 millimeters. So even though we say this is a nice round circle and it looks relatively normal, most of us don't walk around with aortas that are 38 millimeters. So is it possible that if we put a 40 millimeter stent, oversizing only by 10%, and this aorta would increase in size over a couple more years? That would definitely be the case. So that's a very strong reason that we oversize by at least 20% when treating aneurysmal pathology. The second point then is how much length do you want to pick again? So let's say we need to at least land here, because now this is, we can see in the bottom left-hand corner a round aorta, does not have any disease pathology. So the minimum length that we want to cover for this patient is 80 millimeters, 79.4 millimeters. And then the shortest stent in a 44 millimeter length will be longer than that. So it'll probably be a 100 in the 120 millimeter range. So if you were to choose the shortest stent, that would be 44 millimeters in diameter, you'd be able to treat this patient with a single stent graft. The one thing that we didn't talk about the previous stent graft would be vascular access. So coming down into the patient's belly, I'm just going to go back to one of the things that we should do, but we didn't for the sake of time, is try and at least measure what his vascular access is. And by that, we're looking at the size of the femoral vessels here. And if we just blow this image up here, you can actually do a measurement again in the right plane. So this gentleman has, femoral vessels that are at least 10 millimeters in size. As you scroll up, you should scroll up looking for any evidence of any circumferential calcification or any new stenosis, whether it's in the iliac system or the femoral, common femoral, that you want to identify to make sure that you could deliver your stent graft. But in this patient, the smallest diameter appears to probably be in this area right here. He still measures, more than 9 millimeters. And the minimum size that we would need to deliver our stent graft in this patient would be 7.7 millimeters. So we would safely be able to do an endovascular intervention on this patient. Any questions?
Great. Thank you, Dr. Moon. That was a great overview of stent sizing and selection for both different types of patients. So yeah, now I think realistically, there was a question that was left in the chat. This was not actually about the TEVAR, but more about when you're doing your thoracoabdominals, why you switched from left heart bypass to full bypass. Okay. And then I think once you answer that question from the chat, then it's open, free discussion. So feel free to just turn your mic on, guys, and you can ask a question.
Yeah, I switched from left heart to full cardiopulmonary bypass just because it was a technical issue. When I was working in Winnipeg, we did not have the ability to collect all the blood that was spilt during the open cases and then immediately give it back to the patient. And that was an important point because it resulted in a lot of work for anesthesia, hemodynamic instability, and I had concerns about being able to protect the spinal cord. In those open cases, we did not have any patients have a spinal cord injury, but it was a very huge concern of mine. So when I switched to full bypass with full heparinization, to me, the advantage was I was able to use the cardiotomies. We're able to suck all that volume back into the reservoir and rapidly transfuse it back to the patient. As well, I felt that my perfusionists were a little bit more comfortable with that situation, and that was the reason I switched to a full cardiopulmonary bypass. And the second thing was I also got more comfortable using hypothermia, and I felt more comfortable doing my proximal anastomosis open. There were cases where both in my training and in practice we would put a clamp either between the carotid and the left subclavian artery, and I feel that it does increase the risk of vocal cord injuries, and I felt that with hypothermia, open proximal, being able to scavenge all the blood, give back to the patient, I was a lot more comfortable. So as a result, I changed my practice, and that is what I still do, although it was not how I was trained. Any other questions?
I'm just curious, are you guys using somatosensory or motor evoked potentials at the MAS, or?
Yeah, so we're very, very fortunate. In Edmonton, we have probably one of the largest orthopedic spinal programs, and they have they routinely use intraoperative monitoring for every case. Sometimes they will run more than one room. As a result of that, there's almost always electrophysiology tech that is available for us. So for my open cases, any cases that I'm going to be covering below T6 for a stent graft case, or going below T6 for a open case, I will use intraoperative monitoring for those cases routinely along with CSF trains. Don't have to be shy. Any questions? Okay. Well, obviously, thanks, Abby, for the opportunity. If you have any questions, anyone thinks of anything, you can always email me, or you can email Abby and she can forward it to me. And obviously look forward to being able to speak to you guys later.
Yeah, so thank you very, very much, Dr. Moon. Really appreciate you volunteering, or agreeing when I asked you to give the first lecture for this new initiative. And like I said to all those who signed on a little bit later, if you have any suggestions or any lectures that you feel are important to go over, please let myself or Saurabh know, and we will try and arrange a talk for you. But thank you very, very much for everyone who's attended.
Thank you. Have a great evening, everyone.
Thank you.
Bye.